Dr. Helen Fulcher, and I'm speaking with Dr. Massimo Giola, who's a sexual health physician and the clinical lead of sexual health services in the Bay of Plenty. Welcome, Massimo.
Thank you. It's always a pleasure attending the Goodfellow Symposium.
Yeah. Now, we're going to talk about an STI update. I understand there's a few changes, so tell us some more.
Yes. So the title I've chosen for my presentation this morning was Out with the New, In with the Old,
Yes.
or the comeback of penicillin and doxycycline. And there are some major changes happening in the STI world. So the British Association for Sexual Health and HIV Medicine last September issued a statement about chlamydia treatment, and they now recommend using doxycycline 100 milligrams twice daily for 7 days for all chlamydia infections, regardless of the site of infection and regardless of the gender of the patient. And that's going to be a pretty major change.
Yeah,
The next
absolutely.
review of the New Zealand Sexual Health Society guidelines is due in 2020. And we have already started preliminary discussions, and I'm sure we'll have a very robust discussion about this change, which is a
Yes.
major change.
Yes.
But I'm actually expecting other international organisms
Yeah.
going in
Yeah.
that direction. So I'm expecting European STI guidelines, Australian STI guidelines to follow, and
Yes.
we will have definitely that conversation.
Yeah. So there'll be support for that all round.
Yeah, I mean, the
Yeah.
concerns will be possibly about compliance to a 7-day treatment rather than a
Yes.
single dose treatment with azithromycin. But the data are very clear,
Yeah.
and if there was a difference due to compliance, that would have
Yes.
shown
Come
up
across.
in the trial. So
Yes.
doxycycline still ranked superior to azithromycin, definitely for rectal infections, pharyngeal infections, and urethral infection in men, and is equally effective as azithromycin for genital infections in women. So the argument will be, and there is a large amount of undiagnosed rectal infections in women as well.
Yeah.
So the argument will be, really, you should use azithromycin only for pregnant women
Yes.
when there is a clear contraindication to doxycycline,
Yes.
or when you have really serious concerns about compliance.
Yeah.
So as I say, being young and chaotic, it's
Yeah.
probably not enough.
Yes.
But if you do have some serious mental health comorbidities,
Yes.
then you might choose azithromycin for
Yes.
that reason.
Yeah. But otherwise, best practice will be changing.
Well, if someone starts right from tomorrow using doxycycline first line for all chlamydia infections, I don't think they can be criticized
Okay.
at all for
Yeah.
that.
Fantastic.
The other major change that's going probably to happen is about gonorrhea treatment. Again, the British seem to be very keen for innovation during this time, not always for the best, as the Brexit mess
Yes.
is showing to us, but in the
sexual
STI
health, yeah.
field, it seems to be very good innovation coming from the UK. And so again, BESH has just published the new gonorrhea guidelines, and shock,
Yes.
they now advise to get rid of azithromycin from gonorrhea treatment as well, and give everyone 1 gram of ceftriaxone instead.
Yeah.
This is based on a number of microbiological and pharmacokinetic reasons that are extremely complex.
Yes.
But this is the way things are going.
Yes.
And again, other organizations probably will follow. And again, in 2020, this will be another very interesting conversation
Yes.
we will have regarding the new New Zealand Sexual Health Society guidelines.
And if primary caregivers wanted to look up those UK guidelines that are out already and have
Yeah.
read themselves, where
Yes.
can they find them? Just through
Or
the...
just Google BASH. It's spelled BASHH.
Yes.
And they are available in the
Yeah.
public domain.
Yeah. So if they feel confident then that they have a patient who will be compliant.
Well, in theory, we have a New Zealand-based society, so maybe we should allow for the discussion to happen
Yeah.
in New Zealand. And we
Yeah.
know that the process is as important as the outcome.
Yes.
So we want to get to that point,
Yes.
having everyone on board.
Yes.
But I'm trying to get a preview of
Yes.
what possibly will be coming next
Yes.
year.
Yeah.
And then, I
Yeah.
couldn't possibly do an STI talk without talking about syphilis,
Yep.
given the horrendous epidemic we are having currently in New Zealand, and unfortunately the ongoing congenital
Yes.
cases. And so, the clear message I would like everyone to bring home is all women, all pregnant women need to be offered universal syphilis screening
Yes.
at first antenatal bloods.
Yes.
And if women are finding it difficult to access a midwife, and there is a waiting list to see a midwife, I think the message should be from the GP practices, come to us at least for the antenatal
Yes.
screening, and have the GPs involve
Yes.
and step up to do the antenatal screening while waiting for a midwife to take over management.
So we should be proactive about this.
I think you guys should be very proactive about that. And what the new message we are trying to bring to primary care is also to repeat the syphilis screening in the third trimester, because the highest risk for the baby is actually if the pregnant woman contracts syphilis in pregnancy, because early syphilis is the highest risk for transmission, and later in the pregnancy the placenta becomes more permissive as well. So actually that's where the risk is the maximum.
Yeah.
So all women really should have another screening in the third trimester.
Yeah. And again, it's about being proactive for these
Absolutely.
women. Yeah.
And pass on the message to pregnant women.
Yeah.
This is not based on risk assessment.
Yes.
This is not because we think you are at risk. This
Yeah.
is something that every woman needs to do for their own health during pregnancy and to preserve the best health of their baby.
And you've recently done 2 fantastic podcasts on syphilis, haven't you? And it's through the Goodfellow unit. And I think they will be great resources for anyone who has a patient or even just wants to learn and upskill their practice a bit more about
this. At the time, we were still discussing the screening in the third trimester because there was still some ongoing discussion.
Yes.
But the very recent and last case we had in Tauranga is a textbook case for that. So a woman who tested negative at the first antenatal screening and then delivered the baby without any further tests, and the baby was diagnosed with congenital syphilis afterwards. So this woman is a textbook example. She had no risk factors whatsoever, so she's been missed. And if she had a second screening in the third trimester, the congenital infection of the baby would have been prevented.
Wow.
So this is unacceptable. Every single congenital syphilis case is a sentinel event.
Yeah.
It's a never event. The only acceptable number is 0. So we cannot be complacent in any way with that.
Yeah. Fantastic, Massimo. Is there anything else that you'd like to add for primary caregivers?
We had other discussions about gay men's sexual health and implementation of PrEP in New Zealand.
Yes.
And these are probably slightly more specialized fields, but I structured this year these clinics, as you call them at the symposium, as being as interactive as possible with clinical cases, and I think the GPs attending were very, very pleased with that.
Fantastic.
So
you're getting engagement, which is wonderful.
I think so. Yeah.
Thank you very much, Massimo. Nice to talk to you again.
Yeah, pleasure.